Thank you for joining this edition of CME BriefCase entitled Choosing Antiretroviral Therapy. What does the evidence say? Dr. Dr Gandhi has been kind enough to share her thoughts and insights with us today. Dr. Gandhi is Professor of Medicine and Associate Division Chief, Division of HIV, Infectious Disease, and Global Medicine at the University of California, San Francisco General Hospital. Director, UCSF Center for AIDS Research, and Medical Director, HIV Clinic at SFGH in San Francisco, California. Today we will meet Candace, a 62-year-old woman newly diagnosed with HIV. Through the lens of treatment decision-making for Candace, our goal for today's CME BriefCase is to incorporate the latest evidence-based and guideline-directed treatment strategies in the management of patients newly diagnosed with HIV. Welcome, Dr. Gandhi.
Hello, Candace. I'm Dr. Gandhi, and it is nice to meet you virtually today.
Hello, Dr. Gandhi. It's nice meeting you also.
I've had a chance to review your chart that your OBGYN, Dr. Steger, sent over. And I understand that during your annual gynecologic exam, you tested positive for HIV, and I'm here to answer any questions about this.
Yeah, it's just so devastating. You know, I'm 62 years old and I recently emerged from a bad marriage. And so, of course, you know, I've been dating and I did not expect to get a positive HIV result. So this has been very, very devastating to me. I'm always preaching to my children, warning them about using protective measures if they're going to be sexually active. And look what happened to their mom at 62. I end up positive.
Well, you know, I am here to tell you that you are going to be perfectly fine with your HIV. It is completely my job as an HIV doctor to tell you you're going to have a normal lifespan, you're going to be completely fine. I'm going to work with you really closely to ensure that this becomes just another part of your healthcare. And I know it feels this way right now, but it really is my job to make this just a routine part of your health and to know that you have a completely, absolutely full life ahead of you in terms of your lifespan, in terms of your sexual life, and you know, these things absolutely happen, and I'm here to help. So I really want to first say this and just tell you it's a chronic illness, and there isn't a cure, but luckily we have wonderful HIV medications. We have so many at this time in 2020. My job is to make sure you don't have any side effects from those medications, and it really doesn't carry the weight that it did before when we didn't have these excellent medications. We have few side effects, we have lots of good options, and they're much more convenient to take. And you will get to a point where you take a pill every day and you will forget about your HIV. And that is my job to help you do that.
Oh, it's so great that you say this. You know, it makes me feel much better. And it's very comforting to hear that there are a lot of effective treatments and that I can live a normal life with this condition. Thank you.
So I really do want to start not only with that part, but just asking what about your overall health? Just to help me design the best regimen for you, talking through it with you, I do want to ask about any substance use, any intravenous substance use or any drug use.
Oh, no. Heavens, no. I've never used anything except doctor prescribed prescription drugs. No,
Okay.
no type of street drugs.
Okay. Great. So Dr. Stegers is very thorough and already has provided some important information through laboratory tests to help us factor in the decision-making of what to use on you. So I see that you're on a statin for cholesterol, and tell me about that. Your lipids are normal at this point.
Yes, my OBGYN prescribed vitamin D for me and calcium. And at this time, he feels that that's sufficient. And I do have a history in my family of osteoporosis. My brother has osteoporosis. My mom has osteoporosis. And unfortunately, my mom had a fall and she broke a bone. So I definitely don't want that to happen to me. But at the time, the prescriptions that my OBGYN has given me, they are sufficient for me at this particular time, and it's keeping my HDL and my LDL, my good and bad cholesterol, stable right now.
Good. So basically what I hear and see from the chart is there are two things we had to put in our decision making. One is that you are on a statin for your high lipids, but everything has been going great in terms of the statin working, bringing down your LDL. Your HDL is good because that's the good
Yes.
one. We want that to be higher. And then in addition, you had a DEXA scan. And like you said, it showed the osteopenia, which just means the thinner bones, but definitely not the frank osteoporosis, the really getting into territory where we'd be really worried about you. And so you're adequately treated with the vitamin D and calcium now, but we want to avoid anything that pushes you over into the category of osteoporosis, given the impact this has had on your family and your genetic proclivity from your mom and brother. As an African-American woman who is older, it really is important to stress that currently our CDC data show that 11% of new HIV diagnoses in 2018 were among Black or African-American women. And it is important to also note that not only are women at risk for HIV in this country, but older patients are at risk. Like the patient in our scenario, in older ages in life, women and men both sometimes fail to use condoms for contraception protection. And because of that, there can be more of a risk of acquisition of HIV in the setting of non-condom use. And this next slide shows us that really in new HIV diagnosis in the US and dependent areas, though MSM are still most at risk, men who have sex with men in this country, it is important to note that Black MSM are the highest risk group for being newly diagnosed with HIV infection by the CDC data in 2018, and that women, if you look at these slides, are the fourth at risk, with again 11% of new diagnoses occurring among African American women. It's also really important to remember, as we see on this next slide, that HIV diagnoses in older women are not infrequent. Really, a lot of our data on sexual risk and protective behaviors are scarce for older women because research has been focused mainly on younger women. But again, if you're not viewing the need for contraception and condom use, this is a particular time where HIV acquisition can result in older men and women as people date, they're widowed, they're divorced, and these new infections have been coming up. So, as we saw today, our patient is a 62-year-old postmenopausal heterosexual woman. She was referred to your clinic from the OBGYN because she tested positive for HIV during an annual examination. She was divorced after a 12-year marriage. She recently began dating, was sexually active, and her current medications include rosuvastatin for mild hyperlipidemia and vitamin D for her mild osteopenia seen on a recent DEXA scan. Her CD4 count on diagnosis was 195 and her HIV level, RNA level, was 250,000. She's immune for hepatitis B. She is hepatitis C negative. Her BMI is 24. She has no resistance-associated mutations on her genotype. Her AST, ALT, and other laboratory values are within normal limits, but her T-score on her DEXA scan shows osteopenia. So today, at our virtual visit, we discussed substance use, which she does not have as a risk factor. We discussed coming to grips with her new HIV diagnosis. She was fairly distraught, and it really is important for as an HIV provider that we can be so reassuring at this point in the HIV epidemic about how many medications we have available, how few side effects they have, how many options we have, and that people who are on HIV therapy really approximate a normal lifespan compared to those not with HIV, and that a normal sexual life is achievable with all of the data on untransmittable equals undetectable, which we'll go over later in this talk. We want to talk about her sexual risk in relation to the latter point, and we want to talk about treatment goals and begin to assess her treatment options. So this leads me to my first audience response question for you. that we sent a number of labs on her first visit, but which test is not typically sent on the first visit for HIV care? So to start with the typical testing that we perform at an initial HIV visit, one of the mainstays is really to get HIV drug resistance testing, and we start with a genotype. Phenotypic testing is not encouraged nor needed at the first visit, and in fact, we really reserve phenotypic testing for a severely drug-resistant virus, where we're trying to grow the virus in culture and figure out our options. But genotypic drug resistance testing is indicated for newly diagnosed or treatment-naive patients, patients who are experiencing virologic failure, patients who have suspected complex resistance patterns, and if you are considering a CCR5 antagonist, in which case a tropism test would be sent. In terms of other standard laboratory testing, as we had done for this patient, we really send HLA-B5701, we screen for other sexually transmitted diseases, we screen for hepatitis A, B, and C exposure and immunity, and we really screen for our basic laboratory values, renal, liver function, as we go ahead and try to figure out our best treatment option for the patient. In terms of starting treatment for patients living with HIV, there is increasing evidence in the HIV field that treatment should be started as soon as possible. We actually, here at San Francisco General, at UCSF, we start antiretroviral therapy on the same day of diagnosis if we can. And it really speaks to the advantages of rapid ART initiation as listed here. Early virologic suppression after HIV infection improves health outcomes and decreases transmission. Rapid ART initiation really, in a qualitative sense, can give a patient a lot of empowerment. They've been told that they have an HIV diagnosis, a life-altering diagnosis, and they get to do something about it, start treatment that same day. And this qualitative data has been reported from our clinic and others. And really, by the current guidelines, at least the IAS USA guidelines, and now increasingly on the DHHS guidelines, and by the World Health Organization guidelines, we are at a point that major guideline committees recommend that rapid ART initiation should be offered to all people living with HIV following a confirmed diagnosis. And really, the patient has to be ready to start, and it's something to discuss with your patient, but this is increasingly standard practice. Here you can see that I'm going to review data that about the increasing evidence of benefits of early treatment and ART initiation across San Francisco, and this has been replicated in other healthcare settings. As you can see on this first slide, we did an analysis from 2013 to 2017 at Ward 86, which is a publicly insured clinic at San Francisco General Hospital. And we initiated this rapid program in 2013 and saw that even though our patients had multiple concomitant challenges, such as homelessness, substance use, and mental illness, that we had a very high rate of acceptability to starting on rapid ART in the context of this program. 96% of patients wanted to start rapid ART on their day of diagnosis. And then as you can see on this next slide, we had excellent responses in terms of virologic suppression rates right away with our antiretroviral therapy, and even up to a year later, very, very high rates of persistent virologic suppression and acceptance of rapid ART start. On this next slide, you can see that as we've been expanding rapid ARV across the city of San Francisco, that we have massively reduced the number of days that it takes to start ART. You can see that on the right, they used to take a long time from the first care visit to achieve virologic suppression with this slower starting of ART, 145 to 76 days being the median time. In the context of the rapid program across the city of San Francisco, the median days to rapid ARV start has actually decreased to 0, median. And you can see that the median days from first care visit to ART initiation and to virologic suppression has massively reduced. So we are very proud of our rapid program in San Francisco and thinks it speaks to how to roll this out in other cities. In terms of the cost effectiveness of rapid ARV start, this was an analysis that was published this year among 974 Medicaid insured people living with HIV initiated on ART from 2012 to 2017. And people who actually delayed antiretroviral therapy accumulated more total healthcare costs in the 36-month period after diagnosis than those who initiated right away within the first 14 days. So it's a cost-effective, qualitatively better, and as we can see, higher rates of virologic suppression with this strategy. I do want to ask you also, are you currently sexually active, and do we want to think about that when we think about your medication?
Yes, yes. This is kind of, a very sensitive area, but yes, I am sexually active. And now that I've been diagnosed with HIV, I'm very concerned about not exposing my partner to the virus.
So the best part about living in 2020 and being an HIV doctor is I can say with complete certainty that we have at this point wonderful data and from very large what are called observational cohort studies that U equals U. And what I mean by that is undetectable equals untransmittable. The best way for you to protect your partner from being at any risk for HIV is you taking your HIV medication, staying adherent to them, taking them every day. That makes your viral load undetectable, and that eliminates the possibility of your partner getting HIV. And so it's good for you, it's good for your partner. And so that is where we are in the data right now. And I'm very happy to tell people this positive news.
So as long as I'm taking my HIV medication on a daily basis, that keeps my viral load undetectable, and then that prevents me from passing the virus on to a sexual partner?
That is exactly right. We really had a lot of data from that to begin with that was sort of, more observational. And then over the last 3 years, we've had huge amounts of data from observational sets where one partner is negative, one partner is positive. And there have been many sex acts in those multiple studies in both men who have sex with men and heterosexual couples. And the risk of transmitting the virus to another if you keep your viral load suppressed is 0. And this has led really the CDC to put the strongest statement on this, which is undetectable equals untransmittable. And so we will work together to find a regimen that works for you, that doesn't give you side effects, that works with your own health issues, and also protects your partner.
That's wonderful. That's very comforting to know. Thanks.
I also wanted to take the opportunity here to mention the U equals U data. And we spoke to Candace about this, but this is really the advantage of starting therapy and staying on therapy and being highly adherent to therapy in terms of the impact of HIV treatment as prevention. As you can see on this slide here, undetectable equals untransmittable, or U equals U, really has been shown in 3 very large observational cohort studies performed in couples, either MSM or heterosexual couples. These 3 studies were called the Partner Study, Opposites Attract, and Partner 2. And among an enormous amount of condomless sex acts, as you can see is represented in the 3rd column here, in all 3 studies, transmission within partnerships was 0, 0, 0 across all 3 of these large studies if the person living with HIV stays on therapy and maintains the HIV viral load in less than 200 copies per mil. This led the CDC to very strongly state in a Dear Colleague letter last year that when ART results in virologic suppression defined as less than 200 copies per mil, it means that people who take ART daily as prescribed and achieve and maintain an undetectable viral load have effectively no risk of sexually transmitting the virus to an HIV negative partner. This public health messaging is extremely important in terms of reducing stigmatization for those living with HIV and for encouraging a normal sexual life and a healthy sexual life among our newly diagnosed patients, as we spoke about today. Going back then to the patient, how do we think about how to start her antiretroviral therapy? What are the considerations that we need to take into account when we want to factor in what should we start for new treatment for this newly diagnosed patient? So the factors that we consider as HIV providers are really to look at concomitant medications and drug-drug interactions. We want to look at food issues because some drugs need to be taken with food. We want to look at their capacity for adherence, though It is difficult sometimes to ascertain that at the beginning, but to be able to stay on a medication and take a medication daily. We want to look at insurance access, and then we want to look at certain comorbidities. And the main ones that we think about with HIV treatment is bone health, as like in our patient Candace. We think about cardiovascular health and lipids. We think about renal health, and we think about the capacity for some of these medications increasingly to cause weight gain. So in terms of first-line therapies that are recommended for HIV treatment, you can see the recommendations from the major guidelines committees in the United States as illustrated on this slide. IAS USA on the right has only put on as recommended integrase inhibitors, and really only bictegravir and dolutegravir as first-line therapy, citing the low genetic barrier to resistance and drug-drug interactions with alvategravir and the low genetic barrier to resistance with raltegravir, bringing those down and off of first line in the IAS USA guidelines. The DHHS guidelines also do not put alvategravir as first line INSTI for the treatment of HIV, but differs from the IAS USA guidelines in adding raltegravir as first line. And you can see that dolutegravir 3TC is also specifically mentioned to drug therapy in the DHHS guidelines. So we'll go over some of this data now. I do want to say a specific consideration in the DHHS and IAS USA guidelines for a particular patient who has osteopenia. In terms of osteoporosis, at least, in that state, we should be avoiding tenofovir disoproxil fumarate, which can lead to increased bone loss. However, abacavir is an option for our patients who have bone issues. In an NRTI sparing regimen, increasing data on 2 drug regimens with dolutegravir and rilpivirine or dolutegravir 3TC are also possible. The IAS USA guidelines do specifically state that TAF is associated with smaller declines in bone mineral density than TDF. However, because there are still declines with TAF, that is not actually put specifically on the DHHS guidelines for those with osteopenia. Other considerations that are relevant for our patient in the 2 sets of guidelines are listed here. You can see that in the context of hyperlipidemia, that there are certain ARV drugs that are more associated with hyperlipidemia. Those are specifically the protease inhibitors that are boosted, efavirenz and alvategravir, which naturally has to be boosted with cobicistat. Bictegravir, doravirine, dolutegravir, raltegravir, and rilpivirine have fewer lipid side effects, and TDF actually has a benefit for lipids. And so we have seen that switching patients from TAF to TDF actually lowers lipid levels. So in terms of high cardiac risk that this patient is not at high risk for, but we want to watch out because she's older and she has hyperlipidemia as a single risk factor, we absolutely want to think about abacavir and its association, at least recent use, its association with myocardial infarction, but observational cohort studies have been mixed in terms of the protease inhibitor link to cardiovascular disease. There have been examinations of darunavir and the oldest, very old ones that we don't use anymore, PIs being associated with MIs, but there was actually a very large DAD study that atazanavir, ritonavir may have a benefit for cardiovascular disease. So the data is mixed on PIs, and we want to think about it carefully and consider each of them individually. In terms of other considerations, we did talk to this patient today and will talk to her more if the visit proceeds about food issues. Does she have food insecurity? Can she always take drugs with a meal, or does she prefer not her medications to be linked to food taking? We would ask her about dosing options. Does she need or want a 1 pill once a day regimen, of which we have increasing options? We want to discuss weight issues. First bit of data that we got on this, at least the combination of integrase inhibitors and TAF, was from the ADVANCE study. And this was shown both at 48 weeks, 96 weeks, and now even out to 144 weeks at the AIDS 2020 conference, that when participants in South Africa were randomized to dolutegravir TAF FTC versus dolutegravir TDF FTC versus efavirenz TDF FTC, that although efficacy was similar in these 3 arms, the weight gain was higher in those on dolutegravir TAF. And in fact, the weight gain is shown here out to 96 weeks was really much higher in women than men. And unfortunately, in women, it kept on going at 96 weeks, at least in the data that we saw from the New England Journal publication on this. And then when we look at the data that was newly released at the AIDS 2020 meeting, we can see that that weight gain keeps on going out to even 144 weeks in the women. Still increases in men as well, but more pronounced in women, and looks like the weight gain is sort of persistent there. So that really gave a lot of concern about this combination of TAF with the integrase inhibitors. And there was another study that was shown at AIDS 2020 from Kaiser that looked like those who just were started on antiretrovirals and had HIV, as represented by the red line here, in a very large cohort, were more likely to have weight gain compared to their uninfected counterparts. Now, just having weight gain or more weight gain was not linked in this particular graph, as you can see, to a particular antiretroviral regimen. But then this was really just looking at ARVs in general. And you can see on the second slide of this analysis that it didn't matter if you were, the patients were starting underweight or overweight or obese, that the weight gain was higher in those living with HIV. Then to look at specific regimens, a study was presented at AIDS 2020 that was a longitudinal prospective cohort analysis called the OPERA study. And this was an interesting study because it essentially had a large number of people, 8% of people living with HIV around the country in Puerto Rico who were on antiretroviral therapy, representing over 115,000 individuals. And this particular study restricted its primary study question to what happened when participants in this observational cohort switched from TDF to TAF. So just that first question. TAF came out in 2016. What happened when that switch occurred, even if you look at all anchor regimens? And you can see here that whether you were on an integrase inhibitor, an NNRTI, or a boosted PI, there was an inflection point after switch where there was weight gain observed with a switch from TDF to TAF in all three backbones, but it was most pronounced for being on integrase inhibitors. And then the next question that was asked, if you looked at the specific integrase inhibitor within that integrase inhibitor class, was there one that was more associated with weight gain at that switch point? And at least in this analysis, just because it was around the time that bictegravir was not out, just looking at elbapixant, dolutegravir, and raltegravir, the weight gain was more for dolutegravir, elbapixant, Cobi than it was with raltegravir over the first 9 months. And then finally, the question is, okay, well, what if people were switching from TDF to TAF, but also at the same time switching to an integrase inhibitor at the same time? And it was that dual combination, which happened to a lot of participants, of switching both to an integrase inhibitor and TAF that led to the most weight gain that we saw over the first 9 months in any of these analyses in OPERA. You could see that the bictegravir TAF arm participants had a total of 4.47 kilogram weight gain in the first 0 to 9 months. There was less in dolutegravir at 3 kilograms and less in elbapixant ritonavir. So this, I think, showed us some of this interaction between TAF and integrase inhibitors, probably independent effects of integrase inhibitors, maybe more with bictegravir and dolutegravir than the earlier ones. And we have a lot to learn about these interactions and about the significance of weight gain in terms of metabolic effects. In terms of thinking about the three main integrase inhibitors that are on the DHHS guidelines, bictegravir, dolutegravir, and raltegravir, it is important to give a few comments on each. Bictegravir does come in a single pill regimen with FTC and TAF. It has few drug or food interactions and a high genetic barrier to resistance. Though we have the least experience with this drug, it has now been 2 years, and there is increasing evidence that it has a high genetic barrier to resistance. But importantly, there's very limited data in this drug in pregnancy, and it's not to be used concomitantly with TB therapy. Also, bictegravir cannot be separated, and it does not come as its own agent. Dolutegravir does come split apart from TAF and FTC. It actually comes co-formulated with bacavir 3-TC. There are a lot of advantages in that the drug regimen of dolutegravir 3-TC as a single pill combination or dolutegravir bacavir 3-TC as a single pill combination are well tolerated. Dolutegravir does have a high genetic barrier to resistance. There are, again, no food or significant drug-drug interactions except that dolutegravir can increase metformin levels. And though there were initial concerns about dolutegravir over the last 2 years with pregnancy, at this point, the DHHS guidelines have now changed. Dolutegravir is a preferred regimen during pregnancy because of the recent data from AIDS 2020 and the TSAMO cohort showing that dolutegravir really shows no signal of decreased safety for the fetus during pregnancy. Raltegravir, the reason that this was taken off the IAS USA guidelines is because though we've had a long experience with raltegravir, it really has a low genetic barrier to resistance as compared to bictegravir and dolutegravir. It does have few drug or food interactions, very good in hepatic or renal insufficiency, but really should be reserved for patients with those conditions because it requires multiple pills and has its low genetic barrier to resistance. Elvitegravir and cobicistat is not on these guidelines at all because this is also a low genetic barrier to resistance drug, and the cobicistat involves significant drug-drug interactions because of the pharmaco enhancer with cobicistat. And so thank you very much, and our key takeaways are presented here. We really want to explain that this is a time when a patient is newly diagnosed to really explain that we have great options for HIV care, that people living with HIV can have a normal lifespan, can have a normal sexual life, and that we have so many now options for treating HIV that we can really tailor our regimens based on the particular comorbidities of that patient. Second is we really wanted to stress that at this point, rapid ART initiation is becoming the standard of care within the first 14 days of an HIV diagnosis because of qualitative, quantitative, and observational data that's showing advantages of rapid antiretroviral initiation. Third point is that undetectable equals untransmittable is real. Getting your, with adherent use of antiretroviral therapy, getting your viral load down to undetectable or less than 200 copies per mil in very large observational studies, there was no risk of transmission to an HIV negative partner. And this has been a profound change in our public health messaging around HIV prevention to those who are on treatment. And finally, there are a number of considerations, including weight, including lipids, including bone health, including cardiovascular disease, and also food and drug-drug interactions, adherence, the desire for a single pill that goes into our decision-making about what to start on the first-line regimen for naive patients. And all of these considerations have good data behind them, and we went over some of those today. So thank you for listening. And in terms of how to collect credit for this activity, please click on the link to complete the post-test and evaluation online. It is listed here below, and participants can then print their certificate or statement of credit immediately. Thank you for joining us.